Good evening, everyone. Welcome to our 92nd Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. This platform is brought to you by Blue Hills Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Yohannes, a general physician, and today with us to have a presentation on DKA management in pediatrics. Dr. Yohannes Hailu is an assistant professor of child health and pediatrics at St. Paul Millennium Medical College Hospital. So, Dr. Yohannes, the stage is all yours.
Okay, thank you, Blue Hills Ethiopia, for giving me this chance. So today's presentation will be on diabetic ketoacidosis management in pediatrics. So those are the outlines. We will see the definition, epidemiology, classification, some pathophysiology, clinical features, evaluation, and treatment. At last, we will see the complications, and we will have also one example. So, as you know, diabetic ketoacidosis is a triad of hyperglycemia, ketosis, and metabolic acidosis. So, for diagnosis of DKA, so all the three are required. So, when we see the hyperglycemia, the blood glucose should be more than 200 milligram per deciliter. The venous pH should be less than 7.3, or serum bicarbonate should be less than 15 millimole per liter, and there should be ketonemia or ketonuria, beta hydroxybutyrate greater than or equal to 3 millimole per liter, which is not available in our setup. So we will use urine ketone, which should be greater than or equal to 2 plus. So sometimes we may get euglycemic diabetic ketoacidosis when the patient took when the patient took fluid by himself, and after the to the emergency, if he or she presents to emergency, the blood glucose level can be less than 200. In that case, we will say it's euglycemic diabetic ketoacidosis. So the three are required to diagnose diabetic ketoacidosis. So when we see the epidemiology, DKA is commonly seen in type 1 DM, but can also occur in around 5 to 25% of type 2 DM. And it is the leading cause of morbidity and mortality in pediatric patients with type 1 DM. And up to approximately 15 to 70% of type 1 DM present with DKA. Most of the time, in 15% is for developed country, and 50% is 70% is for developing country. Like in our setup, the presentation, most of them around 70% present with DKA. So initially in children with established diabetes, DKA can occur around 6 to 8% per year. So those are some risk factors for diabetic ketoacidosis. For those with diabetes ketoacidosis at initial presentation, age less than 5 years, especially those less than 2 years. If there is any delay in diagnosis of diabetes, including in reduced access to medical care, in case of low socioeconomic status, lack of health insurances, children living in countries with low prevalence of type 1 DM, in this case, both the family members may not have awareness about the diabetic ketoacidosis, so they can present later with diabetic ketoacidosis. The other risk factor is in those patients who have established type 1 DM. So the most common cause of diabetic ketoacidosis is omission of insulin. It can be intentional or unintentional. Most of the time, it is unintentional, but in adolescents, if they are injecting the insulin by themselves, they may omit the insulin intentionally. It can be due to the fearing of the needle, or it can be fearing of the complications like hypoglycemia. So the other is in children with poor metabolic control, if there is fluctuation in random blood sugar levels, also risk factor. The other is if in case of infections, can be pneumonia, gastroenteritis with vomiting, dehydration, UTI. So infection is one of the commonest cause of precipitant for diabetic ketoacidosis. The other is age group, peripubertal and pubertal adolescent girls are at risk. The other is children with history of psychiatric disorders, or if they have unstable family circumstances, these are risk factors for diabetic ketoacidosis in established day. When you see the classification, we will classify decay into mild, moderate, and severe based on venous pH, serum bicarbonate, and clinical. So in our setup, we use only clinically. Most of the time, we don't have the investigations like pH and bicarbonate, so we will use clinical classification. So we will classify, we will say mild when the venous pH is between 7.2 to 7.3, serum bicarbonate level 10 to 15. Clinically, if the patient is oriented, alert, but fatigued, so the estimated fluid deficit will be, in this case, 5%. The other is moderate, when the venous pH is 7.1 to 7.2, serum bicarbonate level between 5 to 10. When there is cosmal respiration means deep and fast breathing. And when you see the GCS, the patient is oriented but sleepy, but he is arousable. In this case, in my moderate decay, the estimated fluid deficit is around 7%. The other is severe, when the pH is less than 7.1, bicarbonate level less than 5, cosmal respiration with GCS can be obtunded, coma, and generally the sensorium is depressed. So the estimated fluid deficit is 10%. So most of the time, it's difficult to differentiate moderate and severe decay. So if the patient is having small respiration, so we can estimate the fluid deficit between 7 and 10, so around 8.5% deficit for both moderate and severe. So those are the commonest precipitants for decay. One is poor metabolic control, missed insulin injection. The other is infection, UTI, pneumonia, acute gastroenteritis, and the most important thing is you should check also injection sites. They are the common sites for infection. Due to the increased stress hormone levels, they can so the peripheral insulin resistance and promotes ketogenesis. So they can exacerbate, they can precipitate the decay. The other is trauma, stress, surgery can be also precipitants. The other is medications like Lasix, steroid can be precipitants. So when you see the pathophysiology here, the pathophysiology is important. You should know the pathophysiology in order to manage the decay. So the pathophysiology, so it results from deficiency of insulin and increase in level of counter-regulatory hormones. So in case of hyperglycemia, there will be increase. The hyperglycemia can be due to the gluconeogenesis or glycogenolysis, which occur in the liver and decrease glucose utilization by the body. So it will here is a graph. So in general, diabetic ketoacidosis is due to the absolute insulin deficiency or presence of stress, infection, or insufficient insulin, which leads to release of counter-regulatory hormones that are like glucagon, catecholamines, like epinephrine, norepinephrine, cortisol, and growth hormone. So, as you know, insulin is anabolic hormone, but in the absence of insulin, there will be the catabolism will be underway. So, due to this counter-regulatory hormone, there will be increased proteolysis, lipolysis, and decreased glucose utilization, and there is increase in glycogenolysis. And here in the proteolysis and protein synthesis will be the proteolysis will be underway and protein synthesis will be decreased. So there will be increase in gluconeogenesis in the liver, and it will lead to all of those pathways lead to hyperglycemia. So in presence of hyperglycemia leads to osmotic diuresis. So there will be loss of fluid and electrolytes like sodium, potassium, phosphate, magnesium, and this leads to dehydration. The other pathway is when you see in presence of this counter-regulatory hormone, especially glucagon, there will be lipolysis. In the lipolysis, there will increment in free fatty acid in the liver, so it leads to the ketogenesis pathway. So in the presence of ketones, the alkaline reserve will be diminished, so it will lead to acidosis and it will increase lactate level. So overall, when you see in DKA, most of the time they are in hyperosmolar state, so it can be difficult to difficult to detect the dehydration easily. So every DKA patient is by definition dehydrated. So those are the estimated average losses in DKA. Water around 70 ml can range 30 to 100 ml. Sodium 6 millimole ranges from 5 to 13. Potassium, the average is 5 millimole. Chlorine 4 millimole. Phosphate 0.5 up to 2.5 millimole. So when you see the clinical features, so the signs and symptoms of DKA are related to degree of hyperosmolarity and volume depletion and acidosis. So the presenting symptoms of DKA in older children includes polyuria, polydipsia. These are due to the polyuria is due to osmotic diuresis, and due to that they will have due to the hyperosmolarity they will have polydipsia. They are fatigued, they will have abdominal pain, nausea, vomiting due to the acidosis, which triggers the chemoreceptor triggers. They may have also polyphagia initially, but due to the ketoacidosis, they will have anorexia later. They will have also weight loss, nocturia, enuresis, and candidiasis. In infants, it's difficult to detect those signs. Most of the time, they will have decreased energy, activity, weight loss, irritability, and they may have also signs of dehydration and candida diaper infection. So they will have also hyperpnea or hyperventilation due to the compensation for metabolic acidosis, and they may have also neurologic findings starting from drowsiness to coma. Most of the time, the same neurologic findings will start after 4 hours after we start the management of diabetic ketoacidosis. So for start mild, moderate, severe, or decay, by definition they are dehydrated, both intracellular and extracellular fluid. So we should evaluate every DKA patient starting from we will start from ABC of life. Is that patient comatose or not? If comatose, if the GCS is less than 7, we should intubate. If there is vomiting, we should insert NG tube and we should aspirate the GI content. So we check the breathing. If the patient is the saturation is below 90, we should supplement with oxygen. We should check also the circulation. So most of the time, the patients can be in hypotension, or sometimes if they develop cerebral edema, they can have hypertension. But shock is not common in DKA for 2 reasons. One, because of the release of counter-regulatory hormones like epinephrine, norepinephrine. So the blood pressure, there will be vasoconstriction and increment in blood pressure in DKA. The other is due to the hyperosmolarity. There will be fluid shift from the extracellular to from the cellular to intravascular space. So most of the time, DKA patients are not in shock. But lastly, if they didn't get they didn't get treatment, so they can present with shock. So we should secure bilateral IV line and we should start bolus if the patient is in shock. So we'll see the management later. The other is we should assess also the severity based on clinical signs. Most of the time, clinical signs will underestimate the degree of dehydration. We should see weight loss. If the initial weight is known, we can calculate the weight loss. The other is pH, and especially BUN and hematocrit levels are important in presence of hyperosmolality to estimate the degree of dehydration. If the patient level of BUN and hematocrit is elevated, so likely the dehydration is severe. So the other is we should assess neurologic status, acid-base status. We should check the venous pH, bicarbonate, respiratory rate to know the degree of compensation, and the laboratory tests like the blood glucose, ketone. Especially in our setup, we don't have beta hydroxybutyrate, so we use the urine ketone, CBC, electrolyte, and the renal function test. So when we see the electrolytes, the sodium one, the first is sodium. So despite the total body sodium deficit, there is initial serum sodium concentration can be very wide. They can have hyponatremia or it can be normal. Most of the time they will have hyponatremia due to hyperosmolarity and due to the solvent drug effect of the fluid. So they will have dilutional hyponatremia. And so we should correct the sodium. So here is the formula for corrected sodium. Sodium measured plus glucose in milligram per deciliter minus 100 over 100 times 1.6. So for every 100 milligram per deciliter decrement in glucose, there will be 1.6 milliequivalent increment in sodium level. The other is serum potassium level. So in DKA patients, most of the time, the total body level of potassium is depleted. But upon presentation, they can have low potassium, they can have normal potassium or high potassium. Most of the time, the high potassium is due to the acidosis. There will be shift of potassium from intracellular to extracellular space. The other is due to management. When we start management of DKA, due to the decrement in the acidosis and osmolality, there can be shift of potassium from the intravascular to cellular space. So we should be cautious on the management. The other is serum phosphate. Most of the time, serum phosphate, magnesium are depleted in DKA. So when we see the treatment, these are the treatment goals. First, we should restore the perfusion. We should correct the dehydration. Then we should stop the ketogenesis. We should restore the blood glucose to near normal level. After that, so we should also correct the electrolytes, especially the potassium. And the other is we should avoid the complications of the treatment and should identify and treat lastly the precipitating events. It's most important in management of DKA. So those are the principles. So we'll see each of them. So the first is we should expand the intravascular volume. And after that, we should start the dehydration management. We should supplement them with potassium, insulin therapy, monitoring, and avoid and treating the complications and treating the precipitant factor. So we will see each of them. So when we see the fluid management in DKA, if the patient is in shock, we will start with 20 ml per kg bolus over 15 minutes with 0.9% normal saline. So after 15 minutes, we will reassess the patient. Still, if the patient is in shock, we will add 10 ml per kg. Still, if the patient is in shock, we will add another 10 ml per kg up to maximum 40 ml per kg. Then we will start, if there is no improvement, we will start inotropes. Because most of the time, the initial fluid can be the cause for cerebral edema, so we should be cautious. So if the patient is in shock, the fluid should be normal saline 10 ml per kg. It should be infused over 1 hour. This is vital in the management of DKA. So it will help us to restore the effective circulatory volume, and it improves the GFR. So by improving the GFR, there will be it increases the clearance of ketone and glucose from the blood. Second is the deficit. So we should categorize them into mild, moderate, severe DKA based on the clinical in our setup clinically. After that, we will estimate the deficit. For mild, 5%, 7% for moderate, 10% for severe. So the type of fluid, we can use 0.45 up to 0.9 normal saline or a balanced salt solution. So we can use 0.9%. It's almost the same with 0.45% normal saline. So we calculate the deficit and we will add the maintenance, especially for severe and moderate decay. We will 2 times maintenance. We will use 2 times maintenance plus deficit minus the resuscitation over 47 hours. So if the patient is in shock, we don't subtract the fluid which was given for shock management. So there should not be oral fluid during the IV therapy. So normally you can, and sometimes in patients with mild DKA and age greater than 5 years, we can resuscitate them with oral fluid therapy. So these are the candidates: mild decay, older children greater than 5 years, if it is established then the patient is tolerating oral intake. So we can use ORS for resuscitation based on the calculation deficit. So in mild decay, we will give them 10 ml per kg of normal saline over 1 hour. Then we will continue with calculation of 5% per kg deficit. So most of the time there is no clear guideline in the management of mild decay. So when we see insulin therapy, we should start insulin after 1 hour after IV resuscitation. So in decay, bolus insulin is not recommended. It may decrease the osmolality rapidly and it may cause cerebral edema. So the dose can be 0.05 to 0.01 units per kg per hour regular insulin infusion. So if there is perfusor, we can add 50 international units to 50 ml of normal saline. So 1 ml of fluid will have 1 international unit of insulin. If not, if perfusor is not available, you can use subcutaneous administration of regular insulin every 4 hours. In alternative, in mild decay, when the IV infusion or rapid acting insulin analogs are not available. This is based on the ICEPAD guideline, and currently practice in Ethiopia start regular insulin with the dose of 0.5 unit per kg every 6 hours. So we can give the first dose half IM and half IV. So the IV should be with fluid. So its bolus is not recommended. It can rapidly decrease the RBS, it can rapidly decrease the osmolality and it may cause cerebral edema. And half subcutaneous versus there is in dilemma half subcutaneous versus half IV and half IM, but in our guidelines we are using half IV and half IM. So the correction of ketoacidosis takes longer insulin infusion than correction of hyperglycemia. So dextrose should be added to IV fluid when the blood glucose is between 300 to 200. So we add 5% dextrose if there is rapid decrement in RBS. So we will make it 10% if the blood glucose is below 200. So most of the time, insulin omission is not recommended to treat the hypoglycemia. So you can decrease it by 50% if the random blood sugar is less than 100. Even if if the child become hypoglycemic or random blood sugar levels less than 70 milligram per deciliter, we can decrease the insulin by half, and after that we can manage the hypoglycemia by 2 ml per kg of 10% glucose. The only indication to hold insulin is if there is severe hypokalemia less than 2.5. So in that case, we should manage it. We should manage the hypokalemia first. Then after that, if the potassium level is improving, we will proceed with the insulin management. So these are the potassium therapy. So as I said before, first we will start the rehydration over 1 hour. Then during that time, we should check for electrolyte, and based on potassium level, so we should manage potassium before initiation of the insulin. So if the initial potassium is normal, so we can add 40 milliequivalent per liter of potassium. Can be potassium chloride. Most of the time, the recommendation is potassium acetate, half potassium acetate and half potassium phosphate, or half potassium chloride with potassium phosphate. If the potassium is between 4.6 to 5, we'll give 20 milliequivalent per liter of potassium. If the serum potassium is low, less than 3 millimole per liter, first we should know. Especially if it is less than 2.5, we should manage the potassium before initiating the insulin. So if there is no electrolyte in our setup, so we can use ECG. If ECG is available, we can use ECG. So these are the signs of hyperkalemia in ECG. If the T wave is peak, tone, short QT interval. Normally, the hyperkalemia is ECG finding is based on the mild, moderate, severe. In case of mild, they will have peak T wave. In case of moderate hyperkalemia, they will have short QT interval and peak T wave. If it is severe, more than potassium level more than 9, they will have wide QRS. The other is hypokalemia. If in hypokalemia, there will be prolongation of PR interval, T wave flattening or inversion, ST depression, and prominent UA. So if ECG and electrolyte is not available, after we resuscitate them for 1 hour, we should see the urine output. If the urine output is adequate, so we will supplement them with potassium chloride. So the potassium chloride will be added with the maintenance. So the maximum recommended rate of potassium is 0.5 millimole per kg per hour. So if the hypokalemia persists despite maximum rate of replacement of insulin infusion, so we can decrease the insulin by half. Still, if there is no improvement, we can hold the insulin until we manage the potassium. So these are the most of the time in our setup we have only potassium chloride. So the follow-up should be also based on ECG and every 4 hours with electrolytes. The other is phosphate. So the total body phosphate will be depleted due to the osmotic diuresis and the poor intake. So typically, if we replace it with potassium phosphates, okay, most of the time it's not recommended to manage the hypophosphatemia, with one exception. In case of severe hypophosphatemia with cardiovascular instability, we may manage the hypophosphatemia. But when we manage the hypophosphatemia, we should look also for calcium. The calcium will be depleted when we manage the phosphate. The other is acidosis. So in acidosis, bicarbonate therapy is not recommended most of the time because it has the risk for cerebral edema. So in only one case we will give bicarbonate if the pH is less than 6.7, and if there is myocardial dysfunction, we will give 1 milliequivalent per kg of bicarbonate over 1 hour until the pH level become more than 7. Otherwise, most of the time it's recommended. It's not recommended to give bicarbonate because it's risk factor for cerebral edema. So while we managing the decay, if the acidosis is not corrected, so we should look for different causes. It can be insufficient insulin to switch the ketones, or it can be inadequate resuscitation, it can be fluid calculation error, so it can be sepsis, it can be hyperchloremic acidosis. Most of the time, hyperchloremic acidosis is due to our management. Most of the time, it's recommended to give after 6 hours of management of decay, the fluid should be 0.45% of normal saline. But if you use 0.9% of normal saline, it may cause hyperchloremic acidosis. But most of the times, hyperchloremic acidosis will be resolved spontaneously. So there is no need to manage it. There is medications like sulfate, other recreational drugs can be the cause for unresolved acidosis. So we should look for those things. The other important thing in management of decay is monitoring. So we should monitor hourly for vital sign, blood pressure, pulse rate, temperature, neurologic assessment, GCS, pupil. We should look for pupil. Most of the time, complication of like cerebral edema will occur after 4 hours of management. So we should assess the neurology. The other is the amount of insulin administration, fluid balance, capillary blood glucose should be checked every 1 hour. So every 2 to 4 hours, you should check serum electrolytes, calcium, magnesium, BUN, phosphate, blood gas. If it's available, it's better to use beta hydroxybutyrate rather than urine ketone. So in our setup, we don't have beta hydroxybutyrate, so we are using the urine ketone. So this is the example of the flow sheet for monitoring DKA patient. You have name, age, sex, address, date of treatment. So those are the components: date, time, vital sign, vomiting. RBA should be checked every 1 hour. It should be documented. Urine glucose level, urine ketone every 2 hours. Neurologic assessment, pupil, input, output, insulin dose, serum electrolytes should be documented. Especially when you are referring the DKA patient, you should document everything that we give. So it's important in the management of decay. So now there is a resolution of decay. We will say decay resolved if the pH is greater than 7.3, serum bicarbonate greater than 15, beta hydroxybutyrate less than 1 millimole per liter, or negative for uric ketone. Here, most of the time in our setup, if the patient can be the decay resolved and maybe ketone positive for some time, due to most of the time beta hydroxybutyrate will be converted to acetoacetate. So in the urine, we are using nitroprusside reaction, which will detect the acetoacetate. So it can be positive for some time. Decay resolved, that's urine ketone can be positive for some time. It can last around approximately 11 hours when we compare it to the ketone, blood ketone clearance. So when to switch to subcutaneous insulin. So those are the criteria. If there is no emesis, if the bicarbonate level is improving more than or equal to 16, if the electrolytes are normal, urine ketone is free, anion gap is normal. So we can switch them to the subcutaneous insulin. So here, the most important thing is should overlap with subcutaneous insulin for 15 to 13 minutes if you use ultra short acting insulins like aspart and lispro. But most of the time we are using regular insulin, so we should overlap it to 1 to 2 hours before stopping the infusion of insulin. So in the transition, the oral fluids should be introduced only when substantial clinical improvement has occurred, when the oral fluid is tolerated and IV fluid is no longer required. In patients with insulin infusion, to prevent the rebound hyperglycemia, we should uh, overlap the subcutaneous with insulin infusion. So those are the standing doses of insulin based on age. For pre-pubertal DKA 0.75 to 1 international unit per kg per day. For pubertal 1 to 1.2. For post-pubertal 0.8 to 1 person international units per kg. So out of the total daily dose, we will make it 2/3 will be given in the morning, 1/3 will be given in the evening. From this, 2/3 will be intermediate acting like NPH, and 1/3 will be fast acting regular insulin should be 1/3. So the RBS should be measured regularly after the patient is out of decay, which will guide us to increase or to decrease the insulin dose by 10 to 15%. So these are the targets. This table is taken from the medicine. So these are targets based on age. For 30-day average blood glucose, for pre-meal blood glucose, and target of hemoglobin A1C. So in pediatrics, the most of the time is conventional type of glucose control, because they are at risk of hypoglycemia. So hypoglycemia will have deleterious effect in the brain, so their cognitive can be affected. So most of the time in pediatrics, especially age group less than 7 years, we are using conventional type of blood glucose control. So next we will see the complications of decay. Most of the complications are they are associated with the management of decay. So reversal of decay is associated with inherent risk that includes hypoglycemia, hypokalemia, and cerebral injury. So mortality is mainly due to cerebral injury. So cerebral edema is the leading cause, the most common cause of death in decay. Most of the time in developed countries, the death rate of decay is less than 1%, but in developed countries, it ranges from 3 to 13%. So it's high in developing countries. Or in our setup also it's high mortality rate due to cerebral edema. The other can be renal tubular acidosis and AKI, which can range from 43 to 64% of children hospitalized for decay. So when you see the cerebral edema, it's the most common complication from the other complications. It occurs 0.3 to 0.9% of patients with decay, and it has high mortality rate. Mortality rate once if it happens, the mortality rate is 21 to 24%. From the overall cause of disease related to decay, it ranges from 60 to 90%. And they will have 10 to 25% will have residual morbidity. Most of the time, the previous thoughts are due to the rapid change in osmolality, which is associated with management. So if you give excess fluid, if you give bicarbonate, if you give insulin bolus initially, can be the causes for cerebral edema. But there are recently new evidences which suggest cerebral hyperfusion and hyperinflammatory states are contributing factors for cerebral edema, but it requires further study. So when you see the clinical risk factors for, as I said before, most of the time cerebral edema will happen after 4 to 12 hours, but it can delay as late as 24 to 48 hours. In some patients, they can present also initially with cerebral edema. It's rare, but it can happen. So some of the theories suggest that some patients will have genetic predilection for cerebral edema. So the most common risk factors are age less than 5 years, severe acidosis at presentation with DKA, increased serum BUN level, low initial partial pressure of carbon dioxide, new onset of diabetes. These are the most common factors for risk factors for cerebral edema. So the pathogenesis of cerebral edema is one. These are hypotheses. So brain cell produces normally ideogenic osmosis in case of severe decay to prevent cell shrinkage. So due to the hyperosmolality, there will be fluid shift from the cell to the extracellular space. So to prevent this, brain cells will release ideogenic osmosis. So relatively, they prevent the cell shrinkage. So when you give fluid rapidly, we will decrease the intravascular osmolality will be decreased rapidly, and there will be fluid shift from the intravascular space to the cellular space, which will cause cerebral edema. The other is cell membrane sodium hydrogen is a proposed mechanism. So sodium hydrogen exchange is more important in case of acidosis. There will be this sodium potassium exchange. Sodium will be accumulated in the intracellular space, so it can when we rapidly treat the acidosis, so the hydrogen ion will be released to cell and sodium will enter to cell. Due to this, there will be solvent drug effect and it will lead to cerebral edema. The other is brain injury due to the dehydration, hyperglycemia, and hypocapnia. These are the theories, possible hypotheses for cerebral edema. Most of the time, it's considered to be associated with DKA management. There are criteria for diagnosis for cerebral edema. These are the diagnostic criteria like abnormal motor, verbal response to pain, decorticate, decelerate posturing, cranial nerve palsy, cranial nerve 3, cranial nerve 4, cranial nerve 6 palsy, and abnormal neurologic respiratory pattern, grunting, tachypnea, Feinstock's respiration. So these are the major criteria. One is if there is altered mutation or fluctuation of level of consciousness, sustained heart rate deceleration more than 20 beats per minute, age inappropriate incontinence. These are the major criteria for cerebral edema. Minor criteria: vomiting, headache, lethargy, diastolic blood pressure more than 90, age less than 5 years. So one diagnostic criteria plus two major, or one diagnostic criteria plus one major plus two minor will have sensitivity of around 94% and false positivity is around 4%. So management of cerebral normal prevention of cerebral edema is vital in management of decay. So if it once happened, we should treat it. We should decrease the rate of fluid to 2/3. We should give mannitol. So mannitol should be on the bedside. So we should give mannitol 0.5 to 1 gram per kg over 30 minutes. We should repeat it if there is no response in 30 to 2 hours. So the effects will start around 15 minutes and it will stay around 120 minutes. Others, we can use also hypertonic saline 3%, 2.5 up to 5 ml per kg over 30 minutes. Sometimes both hypertonic saline, we can use both hypertonic saline with mannitol if the cerebral edema is severe. So we should elevate the head if the GCS is less than 8 or if the patient can't maintain the airway, we should intubate them. And previously, hyperventilation is said to be management in diabetic ketoacidosis, but currently it will have delayed race effect. Later, it will have delayed race effect in the brain, so it's not recommended currently. So after we manage the cerebral edema, if there is no response, we should see other differential diagnoses. So we should have CT scan or MRI. It can be the deterioration of this disease can be due to hemorrhage, thrombosis, or infection. So we should investigate them. Otherwise, initially we can't do the imaging. We should manage it first. The other is treatment of the precipitating factors. The most common precipitating factors are surgery, stress, trauma, infection. So we should see for infection. So here, most of the time, the CBC may not be helpful in case of infection because due to the stress they will have the leukocytosis. So most of the time, clinically, if the patient is febrile, this is one of the relevant signs for diagnosing infection in diabetic acidosis. We should see for infection and we should check for UTI, pneumonia, AG, and injection sites are common sites for infection. The other is that precipitant can be omission or decrease the dose of insulin, so we should counsel them in the management of diabetes. So this is the summary. So initially we should check ABC of life. So we should manage the ABC of life. If the patient requires intubation, we should be intubated. We should check the breathing, we should supplement them with 100% oxygen and circulation. If the patient is in shock, should give 20 ml per kg over 15 minutes. So maximum fluid is 40 ml per kg. After that, we should start inotropes. So if the patient is not in shock, we should give 10 ml per kg over 1 hour. So after that, we will check the electrolytes. If electrolyte is not available in our setup, we should see the urine output. If the patient is passing adequate urine output, we should add potassium to maintenance fluid. So the fluid requirement will be calculated, the deficit will be calculated based on 8.5% of deficit. So fluid requirement equals to 85 ml per kg plus 2 times maintenance over 47 hours. Here we will subtract the bolus if the patient is in shock. If the patient is in shock, we don't subtract the bolus. So after that, we will start insulin. It can be by if the perfusor is available via infusion, 0.1 unit per kg per hour. If the perfusor is not available, we can use 0.5 international unit per kg every 6 hours. The initial can be half IV slowly over 10 to 15 minutes and half subcutaneous with the first dose. Or we can also have IM with the first dose. So the other important point is this: we need to change the fluid. The fluid, if the RBC is more than 300, we use normal saline. If the RBC is 200 to 300, we use 5% normal saline. So we can use DNAs, or we can add 6 vials of 40% in one bag of NAs to make 5% NAs. If the RBC is more than between 100 to 200, we should make the fluid D10. So we can mix between by adding 40%, 12 vials of 40% to one bag of NAs. Maximum we can go up to 12.5% of dextrose. If the RBC is less than 70, we will decrease the insulin by half and we will start dextrose 2 ml per kg, 10% dextrose. Here, the other is if the RBC is not improving with this, some recommendations like BACP, the British guidelines, they recommend to hold insulin. But in our case, we don't hold the insulin because insulin mainly is for the management of acidosis. Other is as I mentioned earlier, potassium. So if it is normal between 3 to 4.5, we should make 40 milliequivalent per liter. Potassium 4.6 to 5, 20 milliequivalent up to. If it is below 3, 60 milliequivalent. If it is less than 2.5, we should manage it. That's the the potassium. After that, if it's normalized, we proceed with insulin management. So monitor should be important. It should be at the bedside, and the other is we will transfer to oral fluid and subcutaneous insulin. As I discussed earlier, the dose can be 0.75 to 1 in pre-pubertal, 1 to 1.2 in pubertal, and 0.8 to 1 in post-pubertal. So this is also the summary. You can see this summary. Finally, these are the references and this is example. So you can calculate it by yourself. The patient, a 20 kg 6-year-old boy who had pH of 7.15 will receive. So how do you calculate the fluid? How do you manage this patient? So first we will assess him whether he have mild, moderate, severe decay. So based on the pH level, it's 7.15, so it is moderate decay. So for moderate and severe, we use 8.5% dehydration. So initially, we will give him 10 ml per kg bolus over 1 hour. Then the deficit, when you calculate the deficit, it's around 1,700 ml. So here we will subtract the initial bolus, the 200 from the 1,700, and we will give him 100. So the calculated fluid will be 1,500, which will be replaced over 47 hours. As we should calculate also based on holiday Sega method, we should calculate the maintenance fluid. For the first 10 kg, 100 ml per kg. For the next 10 kg, 50 ml per kg. For the next 10 for after 20 kg, we will make it 20 ml per kg. So based on that, the total amount of maintenance fluid will be 1,000. The total amount of maintenance will be 62.5 ml per hour. So from the above, from the deficit, it's 32 ml per hour. So so we will make it the maintenance. We will make it 2 times maintenance, and we will add it with the deficit, and we'll minus the bolus if the patient is not in shock, and finally we will give them in 47 hours. So the total amount of fluid will be 94.5 ml per hour for 47 hours. Thank you.
All right. Thank you very much, Dr. Yohannes. So, participants, if you have any questions regarding the topic, you can write down your questions in the chat box so Doctor can address them. Thank you, Dr. Yohannes, for the nice presentation. Okay, so there's one question, Doctor.
Okay, says what about using only NPH as a standing dose in pediatrics? So it's not clear, the question is not clear, but so we don't use only NPH standing dose in pediatrics. As you know, normally the recommended management for diabetes is you should use long-acting and short-acting insulins. So the half-life of short-acting, like for example, if you use determine or glargine, the half-life is around 22 to 24 hours. So it will give you the basal insulin, and you should supplement with short-acting insulins in the during the mealtime. So if you use NPH, the half-life is 12 to 18 hours. So it will not cover the hyperglycemia during the mealtime. The other question is ORS, so in management of decay. So if the ORS contains small amount of glucose, so in case of mild decay, we can use safely. We can rehydrate them with ORS. So in case of mild decay, there is controversy in the management. There is no clear guideline, but most of the time, the patient is mild decay or they are already dehydrated, but it's mild, the 5%. Some recommendations, they use 50 ml per kg of deficit should be replaced with RS. It can be also managed with normal water. That's the amount of uh, glucose in RS is low. We can use RS also simply in case of mild decay. For moderate and severe, oral fluid is not recommended.
Yeah, one more question. When do I give mannitol?
So mannitol should be given as far as we suspect cerebral edema based on the initially mentioned criteria, diagnostic criteria, major and minor criteria. So if you diagnose cerebral edema, you should start immediately with mannitol 0.5. Most of the time in pediatrics with low 0.5 gram per kg over 30 minutes. So you should start them early if you suspect cerebral edema. So if there is no improvement, you can proceed to imaging. Otherwise, it should be at the bedside and you should manage it early.
Does the ORS fluid only manage decay for older children?
Yeah, normally the oral fluid, including ORS, is recommended for age group above 5 and if it is mild decay. Otherwise, for less than 5 years or if the patient is not taking pill, it's difficult to manage that with ORS.
So, in a patient with near normal range random blood sugar on follow-up, what could be the cause of high hemoglobin A1C to the level of 13?
So, hemoglobin A1C will tell us the chronic effect of glucose on hemoglobin up to 3 months. So, the current normal R base can be due to the insulin. So, it will tell us the chronicity. So, it's not if hemoglobin A1C is certain, it suggests there is poor control over the past 3 months.
Okay. Another question by Hewan says, what is the R-base level to diagnose DKA other than the symptoms? Sorry, I was late.
Yeah, this is not clear, but we diagnose DKA if the R base is more than 200 milligram per deciliter. But as I said earlier, to diagnose DKA, it's triad, it's diabetes, ketosis, and acidosis. So ketosis and acidosis also should be there. And sometimes there is euglycemic ketoacidosis, euglycemic diabetic ketoacidosis. Sometimes if the patient took much fluid at home or in nearby health centers, he may have normal glucose level less than 200. In that case, it can be euglycemic diabetic ketoacidosis.
Okay. The next question is, what is the management in the case of euglycemic decay? Do we give the initial bolus IV and IM injection
So,
of?
as I said earlier, so if the patient have ketosis and acidosis and if it's glycemic, we should categorize him based on the clinical symptoms or if you have bicarbonate and pH level to mild, moderate, severe. So based on that, you can proceed. It's the same management principle. But the glucose is low, so we should supplement them with based on the R base level. We can add 5% dextrose to normal salad.
Okay. Another question by Dr. Elias is, if the rate of potassium chloride infusion is 0.5 millimole per kg per hour and there is a maximum limit, If a child of 30 kilogram present, the calculation gives us 15 millimole per hour. Is that appropriate? Even in adults, the maximum is 10 millimole per hour in our guideline.
So normally, yeah, there is controversy on this millimole and milli equivalent per kg. So normally the calculation for millimole per liter to milligram per deciliter is millimole per liter equals to milligram per deciliter times 10 over molar mass. So you can check based on that. So normally the rate should be 0.5 millimole per kg, and there is the maximum limit adult dose is normally we can give 1 milli equivalent per kg per hour 3 times normal setup. So per 24 hours we can give 1 milli equivalent per kg per hour 3 times. So maximum limit ከደረሱ በኋላ we should discontinue the KCL. I'm not sure the maximum dose in adults.
All right. Thank you, doctor. I think we finished most of all of the questions raised in the chat box. So on behalf of Blue Hills Ethiopia and all our participants, we are grateful for you to take the time and present in our Blue Hills virtual seminar, and we hope we will have you in future seminars with other topics related to pediatrics. Thank you very much, doctor. And we also would love to thank all the participants in taking the time to attend the 92nd Blue Hills virtual seminar. So, Dr. Yohannes, if you have anything that you want to add at last, let me give you the chance one more time.
Okay. Again, thank you Blue Hills seminar for having me, and I hope we will meet again. Thank you everyone for attending this webinar.
Okay. Thank you and good night.